Dr. Eduardo Marbán, the director of the Cedars-Sinai Heart Institute and the Mark S. Siegel Family Professor, is an international leader in cardiology and a pioneering heart researcher. Under Dr. Marbán's direction, CSHI brings together physician scientists who are expert in all areas of cardiac medicine to swiftly translate groundbreaking research into state-of-the-art patient care. Using techniques that he originated, Dr. Marbán has completed a first-in-human phase 1 clinical trial exploring whether a patient's own cardiac stem cells can be safely and effectively used to repair damage to the heart muscle caused by heart attack. His topic today: heart-derived cells for the treatment of myocardial infarction. We are delighted to bring to our stage today Dr. Eduardo Marbán. Thank you for being here.
Thank you. So is this microphone on actually? Okay. As we develop this therapy, it's worth reflecting on the developments over the last 12 years. The term cardiac stem cells was actually first used in a patent application by Teresa Deischer, and that patent application was abandoned, and this is really scientific archaeology. The event that actually made some notoriety for the existence of cardiac stem cells was the finding of antigenically selected cells from rats and mice that had stem cell properties, even though those cells were derived from the heart itself, as opposed to the bone marrow or other tissues known to express stem cell antigens. What captured our attention, however, was the work that was being done by the group of Alex Giacomello and Elisa Messina in Rome, using human surgical biopsies and no antigenic selection at all, just a primary outgrowth procedure from which cells could be harvested, and those cells had regenerative properties and could self-organize in suspension and increase post-ischemic function. Even though they were doing this with surgical biopsies, we realized that it could be done in principle with endomyocardial biopsies, and this would lead to an autologous harvesting and reinfusion paradigm if catheters were used on both ends. So we elaborated on this work and derived millions of cardiac stem cells, and specifically what we call cardiosphere-derived cells, from percutaneous endomyocardial biopsies, and use this as a paradigm for autologous therapeutics. Now, the way we harvest and grow cardiosphere-derived cells, which I call CDCs for short, is explained schematically here. We start with a human being in whom we do a percutaneous endomyocardial biopsy, the same kind of biopsy that would be done to monitor a transplant patient for rejection, but in this case is done for tissue harvesting for therapeutics. We then take that biopsy and mince it up into several pieces, each of which is the size of a coarse grain of sand. And this is what one of those pieces looked like on the bottom of a fibronectin-coated dish on day 1. But by day 3, cells come out from the biopsy, some of which are phase bright and easy to see, and some of which are flat and harder to see in this kind of picture. But what we allow in the manufacturing process the cells to do is to reach confluence about 10 to 14 days after plating. And at this stage, if you harvest these cells and put them through a FACS machine to characterize their antigenic profile, you see that they contain a number of stem cell-related antigens. 99% of the cells, on average, contain or express CD105, which is a TGF-beta receptor subunit, and very few, if any, less than 3%, express any kind of lineage markers that are associated with bone marrow stem cells. Instead of putting the cells through a FACS machine, if we put them in suspension culture, where we grow them under conditions where adherence is inhibited, they self-organize into large spherical clusters. They can be large, they can be small, we can control their size, but multicellular spherical clusters that are called cardiospheres that have some interesting biological features. Cardiospheres are too large to infuse into a coronary artery. It would be like like trying to flush a bowling ball down a toilet. So we instead created a dispersed cell therapy product because we wanted to use the intracoronary delivery route for our first clinical trial. So what we did is we took the cardiospheres that were free-floating and replated them on fibronectin-coated dishes, and using FDA-compliant techniques and clinical harvesting methods, we've achieved yields in excess of 25 million CDCs in about 3 weeks. And the process works about 90% of the time. So where are we in the translation to the clinic? Well, we first expanded and optimized the cell isolation, made it FDA compliant. We've now demonstrated, and other groups and labs worldwide have demonstrated regeneration and functional benefits in mice, rats, and pigs. We did a systematic study to optimize the intracoronary dosage so that we could get consistent engraftment but no ballistically related microvascular injury from using an excess number of cells. We performed pivotal preclinical studies, which are all published now, with demonstration of reduced scar and improved hemodynamics in pigs using a double-blind placebo. Well, the pigs never know what we're doing to them, but a blinded placebo-controlled study design. And then we've performed the Caduceus trial, which reached its pre-specified primary endpoints in 2011 and was published recently. Caduceus stands for cardiosphere-derived autologous stem cells to reverse ventricular dysfunction. The criteria for enrollment in Caduceus were that the patient have had an MI within 30 days of screening and LV dysfunction distant from the MI by clinically indicated measures, 25 to 45% ejection fraction. We didn't rush to treat patients after the MI because we recognized that it would take several weeks to manufacture cells from endomyocardial biopsies for autologous therapy, so why rush to therapy? So our patients ended up actually getting treated 1.5 to 3 months post-MI. And the design was a prospective randomized 2-to-1 controlled study with the control being standard of care, dose escalation, safety and preliminary efficacy study, and the key for the efficacy was the use of contrast-enhanced MRI to measure scar mass, viable mass, volumes, and function. This was performed at 2 centers, at the Cedars-Sinai Heart Institute and Johns Hopkins. Cedars was the lead center and enrolled 23 of the 31 subjects. The use of endomyocardial biopsies marked the first use of this study marked the first use of endomyocardial biopsies for therapeutic tissue harvesting. We then manufactured CDCs at the Cedars-Sinai Heart Institute. When a patient was enrolled at Cedars, we would walk the biopsy to the laboratory and then call the patient back and walk the cells from the manufacturing laboratory to the cath lab. When patients were enrolled at Hopkins, they were biopsied at Hopkins. The biopsies were shipped overnight to us, and cells were shipped back overnight when they were ready. And we've looked at the results of the 2 subgroups, and they're identical in terms of therapeutic benefit. So we, even though we've now moved forward from the autologous paradigm to favor an allogeneic paradigm, we nevertheless demonstrated proof of concept that the autologous paradigm was exportable and not necessarily a cottage industry paradigm that requires a manufacturing facility on site. And then we did intracoronary infusions of autologous CDCs. So the key data are shown here, and that is the key efficacy data are shown here, and that is based on contrast-enhanced magnetic resonance imaging and the standard analytical tools for this procedure, scarred myocardium appears as hyper-enhanced white areas within an otherwise black and viable myocardial donut. And here's a patient whose heart is seen in cross-section, who had a large anteroseptal MI that's transmural here and involves about 1/3 of the circumference of the heart. And this patient was imaged 88 days post-MI and 2 days before receiving cells. So he received cells, and 6 months later, this is what his slice looked like at a comparable anatomical position, note the similarity of the details in the trabeculations, for example. And you can see now the scar is much thinner. It involves a smaller circumference, smaller extent of the circumference of the heart. In contrast with a control patient who was imaged 82 days post-MI and then 6 months later, and you can see that this patient had a very large septal infarction that didn't get any smaller over time. So this finding confirms the pessimism that scar, once established, does not go away on its own, and that myocardium that's viable, once lost, does not regenerate on its own. So when we looked at those two prejudices systematically by using volumetric measurements of scar mass on the one hand and viable mass on the other, what we found is that at 6 months and at 12 months, in the patients who were placebo patients, not placebo, standard care control patients, there was no change in scar mass from baseline at 6 or 12 months in either of those groups, nor was there an increase in viable mass or any change in viable mass in those groups. This confirms in these 8 subjects the general pessimism of the persistence of scar and the lack of spontaneous regeneration over time after a sizable myocardial infarction. When we measure scar mass in the patients who received CDCs, however, the differences were quite striking. At 6 months, there was a 9-gram reduction in the absolute amount of scar, and at 12 months, this had gone up to about 14 grams of reduction. To put that in context, the average size of the infarcts to begin with, as measured by scar mass, was in the 20s. So we're dissolving approximately 40% of the scar at 1 year. And if you express it as scar size, it amounts to about a reduction of 50%, an absolute scar reduction from 24% of the left ventricle to 12% of the left ventricle in the caduceus patients, but no significant change in the controls. What really excited us, however, was the increase in viable mass, which was unprecedented in any cell therapy study. At 6 months, there was an increase by about 14 grams. You see that this is a larger scale than that one, a more compressed scale, so the numbers are bigger, and 22 grams increase of viable mass at 1 year. 22 grams of viable mass is equivalent in mass to about 600 million adult cardiomyocytes. And these patients lose something like 800 to 1 billion cardiomyocytes in the course of these 24% MIs. We interpreted this as evidence for therapeutic regeneration because, after all, regeneration is not an increase in ejection fraction. It's not a reduction in scar. It's an increase in viable myocardium. And this is the first demonstration in humans of a therapeutic regeneration effect in response to any therapy. If, in fact, there's a cause and effect relationship between the reduction of scar on the one hand and the increase of viable myocardium on the other, there should be a relationship between those two parameters. So what's plotted here on a patient-per-patient basis is the reduction in scar on the y-axis and the increase in viable mass on the x-axis. And you can see there's a strong relationship whereby the bigger the reduction in scar, the bigger the increase in viable mass. So is this zombie myocardium or is it functional myocardium? It's in principle, we could be turning scar from white to black and causing something that looks MRI normal but wouldn't be functional. So we assessed the regional function in order to get at this using a very fancy method, which is called MRI tagging, or a very model-independent method, which is just systolic thickening, the same way we would analyze how an affected region would contract on the basis of echocardiography. And you can see that the negative strain value is more negative at 6 months in the CDC patients than in controls. That is indicative of an improvement in contractility, and systolic wall thickening improves to normal in the CDC-treated patients, whereas it's still low in the controls at 6 months. So we conclude that the myocardium is healthy and functional. in order to give us further assurance that in fact we're seeing therapeutic regeneration, we went to the gold standard for demonstrating viability, and that is pathology. There were no deaths in Caduceus, so we couldn't do this on human specimens. So we did intracoronary infusion of CDCs in rats and did quantification of scar size, scar mass, and viable mass using Mason's trichrome, wherein the dead tissue is blue-gray and the live tissue is red. And even though it's an entirely complementary methodology, the findings are very similar. A 50% reduction in scar size, a sizable reduction in scar mass, and an important increase in viable mass. We also took this opportunity to look to see whether the increase in viable mass simply reflected overgrowth of preformed cardiomyocytes as opposed to regeneration of new myocytes. And indeed, the cross-sectional diameter of the new myocardium, of the cells in the new myocardium, is somewhat smaller than in the control group, indicating that this must be a demonstration of hyperplasia rather than hypertrophy. So what about overall LV function? Well, it went up in both controls and in cell-treated patients a little bit. The CDC-treated subjects went up by 2 points from 39% to 41% ejection fraction at 6 months. There was a tendency towards a reduction of EDV in the cell-treated patients with a 15 ml point spread, but it did not reach significance, nor did ESV, but the changes are in the right direction. So I'd like to reflect on the meaning of ejection fraction in this population. We have a situation here where scar size is dramatically reduced, and EF goes up minimally, and what does that mean? So this, on the background here, are data from Wu et al. Looking at the relationship in post-MI patients between scar size on the one hand and ejection fraction on the other. And that paper had nothing to do with cell therapy. It was just the natural variability in scar size and how that relates to ejection fraction. And you can see that the bigger the scar, greater than 50% generally being incompatible with life, the bigger the scar, the lower the ejection fraction. Now here are the data at baseline, at 6 months, and at 12 months for the cell therapy treated patients in Caduceus. So the points seen in Caduceus precisely track the expectations based on the natural variability of scar size and make the point that going from here to here is the expected change in ejection fraction for a reduction of scar from 24% to 12%. If we had started off with a scar size of 40% and gone to reduce that to 20%, we would have seen about a 12 or 15% EF change. But since we're very close to normal, even a 50% reduction in scar size does not translate to much change in EF. And I would challenge any study that shows extraordinary changes in EF to explain them on this basis, because this is the only rational basis based on regeneration that I can think for changes in global function. Now, let's reflect on infarct size and EF in this Caduceus-like patient population. Which one is more predictive of events? So this is the population that we studied in Caduceus. The infarct sizes were in the range of 24% at baseline and 12% at the end of the study in the cell-treated patients. EFs were in the 39 to 41% range. That range, EF has absolutely no predictive value when you look at clinical events in terms of 6-month mortality, but there's a gradual increase in 6-month mortality and monotonic increase with relationship to infarct size. So I would argue that the changes in infarct size in this population are much more relevant to outcomes, potentially. This is based on the literature and not on data from Caduceus, because the study was way too small to look at clinical outcomes, but that's a plausibility argument. And another aspect of this work, the relationship between infarct size and outcomes based on natural variability of infarct size. If you have an infarct size that's greater than 18.5% of the left ventricle, you have something like a 10-fold enhanced risk as relative to if your infarct size is less than 18.5%. And I don't think it's coincidence that Caduceus is going from taking patients from 24 to 12%. It might actually be, this is a fantasy, but it might actually be shifting patients from this very high-risk group to the very low-risk group. So in summary, for caduceus, we did an intracoronary injection of CDCs in post-MI patients with LV dysfunction and found it to be safe and effective. We demonstrated tissue regeneration and improved regional function, and also some trends to reverse adverse remodeling. What are the new concepts to guide future clinical trials? Well, first of all, we're extremely encouraged by these data and are already moving on to a 250 patient study called All-Star, which will be intracoronary CDCs and will look at both caduceus-like subjects that are relatively recent MIs, but also at the much larger population of long-term infarct survivors that are out there. And All-Star will use an allogeneic product, which we've shown recently to be safe and effective. This is up to here is what follows directly from caduceus, but based on other work that we're doing, we have discovered that direct injection using endomyocardial catheters is a very viable alternative to intracoronary injection, as is direct injection using a surgical approach. We're favoring the catheter-based injection catheters simply because they're percutaneous and minimally invasive, but there's no reason why cells could not be given effectively as an adjunct to open heart procedures, for example. We also find that when we can directly inject the cells into the heart in a situation involving either a catheter or direct injection, that the three-dimensional microtissues, the cardiospheres, may be more potent than the CDCs, although the CDCs are the only viable product for intracoronary infusion. So this has emboldened us to pursue sicker patients with advanced ischemic cardiomyopathy and perhaps even DCM using direct injection and cardiospheres in what we're calling the Reconstruct trial. And details of Reconstruct can be found at clinicaltrials.org. So I'd like to conclude simply by acknowledging some of the folks who did this work. Thank you.
Very good. Thank you so much for joining us, Dr. Marbán.